Welcome to Forum at 360. I'm Andrew Kitchenman. Today on Forum at 360, we're talking about the idea of having a single payer for healthcare and whether it would be good for Alaska. The topic of single payer moved to the forefront last year when Senator Bernie Sanders championed it during his presidential campaign. With the effort to repeal the Affordable Care Act stalled in Congress, the future of healthcare remains cloudy. Our guests will talk about what single payer is and how the current system could be converted into single payer. We'll also talk about whether there are other methods that can achieve many of the goals of single payer. And we'll talk about what the experience of working in different payment systems is like for healthcare providers. Dr. Carol Paris is a psychiatrist and the president of Physicians for a National Health Program. She worked for more than 25 years in private practice, community mental health, prisons, and universities. In 2009, she was arrested in a U.S. Senate committee hearing on the legislation that would become the Affordable Care Act. She was protesting the lack of testimony from single-payer advocates. She also participated in the Mad as Hell Doctors campaign for single payer. She lives in Nashville, Tennessee. After Dr. Paris talks, we'll expand the discussion to include Sandra Heffern. She's a policy expert who works with AK Health Reform, a coalition of providers and foundations. And Dr. David Miller is a general surgeon in Juneau who has worked in a form of single payer when he served in the Air Force. Please welcome Sandra Heffern, Dr. David Miller, and Dr. Carol Paris.
Well, thank you for having me, and I'm glad it's a rainy day in Juneau because it's nice to see so many people here. And I was warned that if it was a beautiful day in Juneau, we might not have quite the same turnout. You can tell by my introduction that I am an outspoken advocate for a national health program. But I want you to really understand that as the president of Physicians for a National Health Program, I really represent 21 to 22,000 doctors, medical students, and health professionals who have been doing the policy and the evidence-based research to suggest, to support a national health program and why we need it in this country. We've been doing this since 1987. And it's only more recently that some members of PNHP have also chosen to become sort of the more activist arm. I'm not going to be talking about that today. I'm proud of my activism, but what I'm really going to be talking about today is the evidence base for a national health program. So I've sort of titled the talk, Let's Talk About Single Payer, and I'll talk for 20 minutes or so, and then I think the more important part of this is the discussion where you get to decide or think about whether this is an idea that makes sense for the people of Alaska. So when I talk about single payer, it's also known as a national health program. It's got lots of names. This will just take a second, though. A universal health care, sometimes we call it HR 676, which is the name of the piece of legislation before Congress right now that has 117 co-sponsors. The name of that legislation is Improved and Expanded Medicare for All. Sometimes you'll hear it referred to as Improved Medicare for All, sometimes National Improved Medicare for All. Medicare for All. We give it a lot of names, and that's part of the problem, but it is what it is. I mostly will be calling it single payer. And what do I mean by single payer? Basically, if you think about our healthcare system as being composed of a delivery system and a financing system, what a single payer is we're not talking about changing the way we deliver health care in this country. It stays the way it is now. I said privately delivered, but what I really mean is the way it is now, because some care is delivered privately, some is delivered publicly. What we're really talking about with single payer is how we fund health care. And that would be a change from how we do it right now. And I would just like to make the case that the reason for doing this is really that it's just common sense. So what do we have right now? Well, right now, we have multiple payers. And who are those payers? Well, we have employer-sponsored health insurance, and that's a big chunk of the pie. We have Medicare and Medicaid, which is public dollars. We have other public funding, which would include the NHS, or not NHS, the Indian Health Service and VA. And then we have a large population that is uninsured. So the biggest part of it is the employer-sponsored health insurance and individual insurance. What we propose is a single payer, and it really is pretty much putting everybody in the same risk pool. And if you think about insurance, what's the point of insurance? It's to spread risk. And what's the best way to spread risk? Put everybody in the same risk pool, and that way there's the greatest likelihood that there are enough resources to cover the people who are sick. Well, why change what we do now? Well, actually, we could save $500 billion a year that currently goes to health insurance companies for their administrative costs and profit. And that's a pretty big, staggering number. It's not quite as big as the number that represents what we currently spend on healthcare in this country. At 17.7% of GDP, we're actually spending $3.2 trillion a year to cover 325 million people. So if you do the math, that works out to just under $10,000 per person per year to cover the cost of health care. That's a lot of money. And every other developed country in the world is able to provide health insurance for their entire population at a per capita cost of somewhere between as low as $3,000 per capita up to, I think Sweden is a little over 6,000. So at 10,000, we're pretty much of an outlier. And it's safe to say that except for Sweden, every other country that has a national health program does it for half what we do or less. Now, we can talk about what other countries do, and I certainly will be the first to say not all of them are doing a single payer model. Some of them have, as Germany does, what they call sickness funds, and those are insurance companies that provide the policies for the German people. But those are insurance companies that function very differently than insurance companies in the United States. They are highly regulated, they are not investor-owned, and their responsibility is to insure the people of Germany in an equitable and cost-effective way. That isn't quite the fiduciary responsibility of the insurance companies in the United States. Their job is to make a profit for their investors. They are investor-owned and they make a profit. That's their job, and they do it very well. They do it very, very well. Those figures are what those particular CEOs make in one working day. The average family of 4 in the United States has an income of $42,000 to $43,000 a year, and all but Bruce Broussard are making that in one day. And here's what happens to, here's where the money is going. This kind of shows where the profits are. And what we're targeting at this point are the insurance companies, although built into the legislation is also the recommendation that we negotiate drug prices. And if we did that in this country, we could save another $100 billion a year. So we could save $500 billion by eliminating the administrative cost and profit in the insurance industry, and another $106 billion by negotiating drug prices. And it turns out that's enough money to insure the 28 million people in this country that we're paying $10,000 per capita for, but who actually are not getting any health care except what they get, you know, in the emergency room and at some of the most expensive costs to us. So it just doesn't seem to be a particularly good use of our tax dollars. And when you remember that pie chart, a large part of the, even people who fall into the employer-sponsored health insurance are people who are getting their insurance like federal employees and state employees. Their insurance is paid for with our tax dollars. So it turns out when you lump Medicare, Medicaid, federal employees, state employees, VA, all of that together, it turns out we're already covering about $6,500 of that $10,000 with public funds. And if you remember, I said every other country provides health care for their entire population for mostly less than $5,000 per capita. We're actually paying for a national health program in this country. We just aren't getting it. Now you could say, yeah, but what are their health outcomes? Well, unfortunately, their health outcomes, that's not a particularly compelling argument because their life expectancy is better than ours. Infant mortality, maternal mortality, better than ours. Now, please don't misunderstand and think that I'm suggesting that healthcare in this country isn't some of the best in the world. It is. We have fantastic doctors, hospitals, technology, innovation, and if you can afford it, you can have it. And your life expectancy will be much higher. Unfortunately, we have to factor in when we're talking about public statistics the 28 million people who don't get any health insurance. And they have a tendency to not live as long, a whole lot not live as long. And they have more problems with maternal mortality, infant mortality, the other measures that we look at. So we're paying for a national health program, we just aren't getting it. This is one of my favorite slides. I'll populate it in just a minute. Just pay attention that the blue line will be the growth in the number of physicians between 1970 and 2015. And the red represents, we roughly called it managers, but administrators and managers of health insurance. So these are the billing clerks in hospitals, the billing clerks in doctors' offices, the people that you call on the phone when you want to get pre-authorization and they put you on hold for half your morning. So here we go. That's the growth of doctors and administrators of health insurance, doctors, and then the growth of managers of health care in this country. That's where that $500 billion is. And I would just like to suggest that that's not the best use of our tax dollars, because those people are not contributing anything to the health of the American people. Even Warren Buffett said recently that the cost of health care, actually he said health insurance companies are a tapeworm on the American economy. And if businesses want to save money, they would be better, their time would be better spent divesting themselves of the responsibility of providing health insurance or doing something about that than worrying about their corporate tax rate. Here's a slide that just, as I said, shows $6,400 is public dollars, the remainder being what we spend in private dollars. That's copays and deductibles and things like that. So if you had $3.3 trillion to design a healthcare system worth $3.3 trillion, what would you like it to include? Health. Health? Okay.
Cover everybody.
Cover everybody. You get the prize for the first answer. We'd like it to be universal. Would you like it to be affordable? Because in fact, for the benefits that accrued from passage of the Affordable Care Act, for very many working class people who don't qualify for a subsidy and don't qualify for Medicare or Medicaid, it's not affordable, and it has become exceedingly more unaffordable. So I very much can resonate with the more conservative members of our society who are angry as all get out at the cost of their insurance premiums. But I think they're not looking at the whole picture. So we'd like it to be affordable. We'd like it to be accountable. And how about accessible? And how about comprehensive? How many people actually, when they make their decision year after year after year, when their insurance decisions have to be made, really drill down and look at what is covered and what isn't? I think most Americans are, what's it going to cost me, and how can I keep my costs down? And if you stay young and healthy, that's okay. The problem is if you get sick or get older and have to use that insurance, you find out that it really doesn't cover all the things that you thought it did. In fact, besides uninsurance, underinsurance is an enormous problem in this country, and many working people are one job loss or one major illness away from bankruptcy. So we'd like it also to be high quality and evidence-based and fair. I'm good with that. So we have a piece of legislation, and I'm going to just talk a little bit about what it is. It's called, you don't have to read that, don't try to read that, HR 676. But you can actually go home, go to the PNHP website, click on HR 676, and you can read the 19-page bill in half an hour. It's not real complicated. To review, single payer means publicly funded, privately delivered health care. Also meaning we take our Medicare, traditional Medicare, we improve the heck out of it first, and then we expand it to everyone. I did not realize when I came to Alaska that Medicaid pays better than Medicare in Alaska. So I'm understanding that Medicare for all would not exactly play well here. We're talking about improving the benefits. So people who are currently on Medicare and have to have a supplemental policy to cover their copays and deductibles and their donut hole and Part D and all that stuff. We're talking about eliminating all of those things. You're not going to need all those other supplemental things. You simply will get your Medicare card the day you're born, and you'll lose it the day you die. And what's that Medicare card going to cover? I'll come back to well, it's going to cover all these things. Primary care, preventive, nutrition, inpatient, outpatient emergency, prescriptions, long-term care, mental health, full scope of dental, basic eye, substance abuse, chiropractic, and podiatric means feet. So it's portable, which means you no longer are tied to your job. You can change jobs. You can decide to become an entrepreneur and not have to worry about not having insurance. There's no cost sharing, as I said, no copays, nothing, no barriers to care at the point of service. And that's really important, and we've done a lot of research on that, because we do hear people say, oh, but you have to have skin in the game. Actually, there's not any good research to show that that is beneficial. Skin in the game is really, really costly. The minute you start having to collect copays, you've got to have somebody to collect them. You've got to have somebody who bills when the patient comes in and doesn't have their copay. And then you've got to track that. And if it's a copay that's one thing for one person making this amount of money and a different copay for somebody else making a different, suddenly we've started adding back all that bureaucracy. And it actually doesn't pay. It's just easier to eliminate all of that and let somebody who has a headache and doesn't know why they keep getting a headache go to the doctor, and maybe we find out they've got high blood pressure. And wouldn't you rather have us be treating high blood pressure right up front than have that person be afraid to go to the doctor because they can't afford their copay and deductible? And maybe they can squeak by for a couple of months or a couple of years until, God forbid, they have a stroke. Do we want to be paying for their stroke when we could have been paying for their high blood pressure medicine? That's what I mean by it's just common sense. So, as I said, it's portable, no cost sharing, free choice of provider and hospital, which is where we can let the market actually do its job. And I'll say, we can get into that maybe when we get into Q&A. So I think, who's in favor of this? Well, this is a poll from April of 2017 that shows that 60% of Americans, when asked, do you favor Medicare, expanding Medicare to provide health insurance to every American, 60% said yes. And even 40% of self-identified Trump voters said yes. So this number is changing, and I think what it reflects is that more and more we are, as a people, realizing that this is not something that is pie in the sky, that this is actually feasible, and it's actually a common good. It's in my best interests for all of you to have health care. It's in my best interest from a public health standpoint, from a business standpoint, and from wanting to have my tax dollars used the most efficient way possible. So it is popular, and I'll stop there. These are some websites where you can find a lot more information, because obviously I've left a lot out, and that we'll get into that in the Q&A. But especially at pnhp.org, we have a section called FAQ, Frequently Asked Questions, and we've been answering these questions for 30 years. Thank you.
Thank you, Dr. Thank you, Dr. Paris. So we'd like to involve our other panelists. Sandra Heffern, you've been working on health reform issues in Alaska in recent years. Has the idea of single payer come up in Alaska?
Well, I think in some circles, that's a little loud. Anyway, in some circles, yes, the conversation does come to single payer, but I think it's not so much talking about a single payer, but it's really looking more at a single administrative function. I can agree that the administrative costs and the administrative burden on providers is tremendous as a healthcare provider. I'm not as convinced that single payer is necessarily the direction for us to go, that's really where we're going to see all of the savings, because as you pointed out, Dr. Paris, what you're focusing on initially are the insurance companies. Well, the pharmaceuticals, the hospitals, the physicians, everybody has administrative costs, and everybody has some level of profit. If it's a nonprofit, you call it something other than profit. You call it retained earnings, but it's still, there's some level of profit. So if we were able to do some type of an administrative structure that was managing all of the plans, I think that we would be able to realize additional cost savings that way. The other thing that, fundamentally, I think that one of the things that we have not really grappled with, although you talked about universal health care, I don't think that philosophically as a society that we've actually grappled with universal health care. Is that the philosophy? Is that the value that we want in our healthcare system? Personally, absolutely. I'm a firm believer in universal health care. When I've looked at the other countries, you talked about Germany, but when I've looked at the other countries, they didn't start out with, well, we're going to have a single payer system. They started out with, we want to provide universal health care for our citizens. And some countries have done it through a single payer system. Some countries have done it through insurance mandates, Germany being one of those that's done it through insurance mandates. Even with countries that have a single payer system, they might have a tiered system, so that it's like you've got basic coverage for everybody, and then if you want to purchase additional coverage, you're able to do that through that kind of a structure. So again, I think the single payer, sometimes it's a bad word to say it in Alaska, but that single administrative structure, like under Senate Bill 74, which was passed in last year's session, well, I guess 2 years ago now, 2016, there was a feasibility study for a healthcare authority. And the idea with a healthcare authority was, as we talked about, being able to pool additional covered lives, so that you had additional purchasing power. Looking at state employees, retirees, the political subdivisions, school districts, Medicaid recipients, all of those covered lives under one authority that's managing the plans. Would we be able to realize some cost savings from that? There's, I think, 3, maybe 4 reports that were just released to the public on Wednesday that does talk about whether or not there could be some savings. Is it something that our state's going to do? We have a lot of work to do with that, to really analyze what those reports have to say and see whether or not that would be a good structure for us. Might be a good first step, but I don't know.
Dr. Miller, you served in the Air Force, kind of a form of single payer that you were in, and now you're in private practice. Could you compare the experience of those two?
Certainly. I understand that Dr. Paris's remarks tried to draw a line between healthcare financing and healthcare delivery, and I'd like to respect that line as much as possible. However, during my time in the United States Air Force, we went through several transitions from the medical corps, from Champus to TRICARE. What we saw were hospitals that were consolidated into clinics, turned off the lights at 5 o'clock, and then the dependents and those who were eligible for care were forced into the community healthcare delivery system. And what TRICARE was willing to pay was commensurate with what Medicare and Medicaid were paying at the time. Several colleagues that I know never really endorsed that type of system and didn't accept TRICARE patients electively. Of course, they would take care of them emergently. So I think that anytime we have a major change in the way we finance healthcare, we can expect there'll be a major change in the way we deliver healthcare. It's such a complicated issue, it's very difficult to predict what can happen. I have to say, though, that I agree with Dr. Paris broadly. My personal experience with insurance companies has been as someone who was completely naive to the concept of being paid by an insurance company. When I was in the military, I was paid a wage. I was paid a salary. And I observed people in the military that were doctors that weren't doctors anymore but got paid the same I did. They were administrators, doctors that wanted to be administrators. The nurses we had a name for, we called them clipboard-carrying nurses. As they increased in rank, the doctors who were taking care of patients came to attention when they walked into the room. Yet these people had not actually physically touched a patient in the delivery of health care for months, sometimes years. My concern is that the way we pay for health care may at some point impact the way we deliver health care, and I think that's one of the biggest concerns that my colleagues have.
Dr. Paris, You talked a little bit about pharmaceuticals, and I wanted to return to that. I know one defense that's been offered to the profit-based part of funding pharmaceuticals is that the U.S. has had a disproportionate share of new pharmaceuticals over time, and supporters of the system basically say that some of that's in response to the profit motive, and that every other country in the world has benefited from the profit motive in the United States. So all the other single-payer systems have benefited from the profit motive of pharmaceutical companies in the United States. What's your response to that?
Well, actually, the majority of the basic science research that ultimately leads to a new pharmaceutical is paid for with our tax dollars through the NIH and grants to universities where the research is done. And it's only until much later in the development process that it then gets sold to a pharmaceutical company to do the pre-market testing and then to bring it to market. So we're actually, when pharmaceutical companies say that a big part of the cost of a drug is the research, that's not quite as accurate as they'd like you to believe. And if you look at many of the new drugs, I'm a psychiatrist, so I know specifically about psychotropic medication. And if you look at the majority of the new drugs that are brought to market that are psychotropics, they're what we call Me Too drugs. So they'll take a drug that has just lost its, or is soon to lose its patent, and they'll tweak it just the tiniest little way, and then do a couple more tests to get it through to show that it's better than a placebo. It doesn't even have to be better than the drug that it's replacing. It just has to be better than a placebo. And then they get another 7-year patent on it and charge a lot of money. So I think there's a lot of game playing in the pharmaceutical industry. Yes, they bring some good drugs to market, but actually Cuba has several new drugs that we don't have in the United States because of political decisions between the United States and Cuba. So we're not the only country doing pharmaceutical innovation.
It's in the last decade that I guess the two states that have seen steps toward implementing single payer at a state level were Vermont and California, and both states stopped well short of it. Vermont maybe got a little further along before not advancing it, and then it was stopped in the legislature in California this year. What are your thoughts on a state like Alaska looking at the concept of single payer? Do you think it's possible at a state level? And also I'd like you to respond to some of the points that Sandra made about what has been happening in Alaska.
I don't think that a state like Alaska has the population base to enact a state single payer legislation. I think it would be a mistake. I also, since I have been here and have gotten to see how especially the Alaska Native delivery, the Alaska Native system, I think could be a demonstration case for how to do it in the rest of the country. It is amazing to me the innovations that have taken place, both on the just really good use of their financing, but then in their delivery as well. The decisions they've made and the way they deliver care is amazing. I mean, all the way down to I forget what they're called, community health aides. Community health aides. I mean, that's just not something that happens in the lower 48. And And yes, it came out of a need because there's isolation here, but it's also a very cost-effective way to deliver some basic care that doesn't necessarily have to be delivered by even a mid-level practitioner, and certainly not by an MD practitioner. So I think Alaska has done some really amazing innovations that way. As to your point, what you have described is sort of the case of making your risk pool bigger. And we're just saying, make your risk pool bigger and then get even more bang for your buck, because if you eliminate the insurance industry, there's a lot of money to be gained that could be then channeled into the delivery side of healthcare.
I've heard people say that in the current system, an employer can switch insurers. In effect, employees could complain to their employer about their insurer. If you're on the individual market, not in Alaska, but in other states, you can switch insurers. Can't do that in Alaska, at least today. And that provides a level of accountability, and with the government and the size of the government, people are concerned that they're not going to have the ability to, who they'll be appealing to if they're unhappy with the decision is the government itself. And what's your response to that idea?
Who do you appeal to now if you don't like the decisions that are made by your insurance company? And would you rather appeal to an entity that is either public or quasi-public, that has its responsibility to meet the needs of the American people as their primary responsibility? Or would you rather have those decisions being made by an insurance company that has a primary responsibility to make a profit and actually calls any money that they spend on actually covering health care, it's called their medical loss ratio. So we're actually, as people who become sick, a loss to the profit margin of the insurance industry.
Who, by the way, had their best first quarter since the Affordable Care Act. $4.5 billion in profit for the top five, or the big five insurance companies, first quarter of 2017.
Sandra Heffern, do you see any aspects of the current system that you might be concerned we might lose if we were to shift to a single payer system?
So Andrew provided me with a few questions before tonight, and this was the one that I really struggled with because I don't know. I mean, quite honestly, I don't know whether we would lose something. I think that we would have some providers who may come into the state because we were more attractive. We may have other providers who choose to leave. Alaska is still a fairly young state. You know, we've spent the last 50 years building our healthcare system, you know, trying to come up with innovative ideas like community health aides or dental aides. And whether a single payer system would somehow restructure that, I don't know. I don't know. I do want to talk about a couple of things. I'm pro-business. You know, I ran my own company for 20 years. It was a healthcare organization, and I sold it about 7 years ago, which then gave me an opportunity to do consulting and contract work. We made a profit. You know, we put our profit back into our organization. I competed, if you would, with nonprofits, and my rates, my reimbursement rates, were lower than what the nonprofits were until the state set the rates, you know, across the board. But my rates were lower as a for-profit organization. I don't think profit is a bad word. I was also a past chair of the Anchorage Chamber of Commerce Board of Directors, so I really am a pro-business person. So I kind of had to get that part out. I think the other thing too is that as we're thinking about changing or possibly changing our payment structure or how we're managing our payment structure for healthcare, I do believe that we also have to look at how we're delivering. You know, we have to come up with a better way of managing care. You know, healthcare it's a resource. It's a goods and service. Everything else, we look at that from a resource allocation kind of a perspective. You know, how much is out there and how much can we provide, or how much can people get? And I don't think that we talk about healthcare from that perspective, because as soon as you start talking about allocating resources with healthcare, you know, it's like you start going down the road of death panels and where, you know, people aren't going to be able to get service. But I don't look at it that way. I mean, I think that we have a finite amount of service. We have a way that we can deliver that, and it costs money, you know, and that's kind of the reality of it. Some of us, when we're looking at the healthcare delivery system, we're trying to change that as well. You know, we're talking about a comprehensive healthcare plan for Alaska. You know, not the one-offs that we tend to. There's an issue, we're going to come up with a solution, and we're going to deal with that solution, but not really looking at the whole system. And so there's kind of this groundswell right now of trying to look at all of healthcare, bringing in the insurance companies, the payers. I look at it as the 4 Ps: the payers, the providers, the patients, and the policymakers. Trying to get all of those people together to talk about what does our healthcare system need to look like. You know, do we want universal healthcare for the citizens of Alaska? If you ask me, yes. But, you know, again, that's just my personal opinion on it. You know, but really trying to get all of those people in a room so that we can get everybody's perspective and fix what our healthcare dilemma is.
I want to include some questions from the audience, so if people who have questions could start lining up at the microphone, I'd appreciate it. Dr. Miller, what do you think? What are you thinking as you hear these comments?
Well, I think that I came here fairly unprepared for this conversation, but I think that it's such a complex issue that the little bit of preparation I did, you know, I took a look at Bernie Sanders' bill. Yeah, I thought a lot about my experience in delivering health care in Alaska since 1995. And I think that many of the points that have been made here are very valid. My personal experience of being a patient is worth noting. I needed a colonoscopy. I was 6 months from my 50th birthday. My insurance company said that I had to be 50 before my colonoscopy, even though I'd had some symptoms and a family history of colon cancer, so I waited. During that 3 months that I waited, I paid over $2,000 a month in insurance premiums. So I finally turned 50, got my colonoscopy done. The colonoscopy cost less than my deductible. So my insurance company made $2,000 for me that month, and I paid for my colonoscopy, and they delayed my care by 3 months. So I'm no fan of insurance companies.
Are you concerned that payments to providers could be decreased in Alaska?
That's a given. I mean, but I think that you have to look at both sides of it. You know, you need to look at what's best for the patients first, and then you have to look at what's best for your profession. If you have to put it in an order, you have to look at that second.
Could I respond to that also?
Sure.
More than wanting to pass a national health program in this country, I actually want to have it be successful. So this is the 52nd anniversary or birthday of Medicare. And when I got my Medicare card 2 months ago, and I actually get to start using it next month, the first thing I did was cover my Social Security number and take a picture of it and tweet, "Hallelujah, in 3 months I get health security." And what do we hear our senior citizens saying? Don't touch my Medicare. Well, 52 years from now, I would like my grandchildren to be saying, don't touch my Medicare. And I would like 12-year-olds to be saying, and don't touch my Medicare either. So I want it to be successful. Well, it's not going to be successful if we offer a fee schedule to physicians that makes them all flee to Canada where they can make a better living. So we have to have a competitive fee schedule. And yes, there will be some physicians, I think primarily in Alaska, where there is this really peculiar way for specialists to define their reasonable and customary and then get paid 85% of that. That doesn't happen, 80%. So there will be some losers. There will be some physicians in Alaska who will make the same as a specialist, will make the same as a comparable specialist anywhere else in the United States. And for them, they may feel like a loser. But I would like to just tell you about a physician I met last night before I got on the plane to Juneau. Just finished her residency in family medicine in Wisconsin and has moved to Anchorage because she said, I wanted to go to the place that was the closest I could get to a single payer system. And she's working at Alaska Native Medical Center. And she did that because she wants to be a doctor. She doesn't want to be a doctor of Medi-business.
I wanted to ask one last question, sort of a political question, which is that I believe that historically a concern has been raised that in moving to a private insurance-based system to a federally government-run system, that essentially you'd be switching from the premiums that people pay and employers pay to a tax-based system. And it's been shown over time that people respond very negatively to, they respond to politicians who make the case that this is going to increase taxes, that people essentially have a greater concern about the potential loss of their current insurance than imagining the potential of what it would be in the future. What's your response to that dilemma?
I think that's a very natural concern that people have. They hear the word tax and they immediately think my net income is going to go down. In fact, for 95% of Americans, we would institute a modest tax that is a progressive tax, meaning if you make less, you pay less. If you make more, you pay more. And at the end of the day, your taxes would go up modestly and your net income would go up even more, so that you would have a net positive outcome. And that's because you can't just talk about the taxes, you have to also talk about what you're now not paying out of pocket. And what's happened to everyone's premiums over the last few years? What's happened to everybody's deductible over the last few years? Premiums, I think it is, has gone up 242% over the last, I forget the statistic, 10 years or so. So it's what is not coming out of our pocket compared to what comes out in taxes and what the net result is. So that's my response.
Thanks. So could you identify yourself and ask your question, please?
Sure, I'm Chris Cairns. I want to thank you guys for being here. Dr. Paris, I noticed when you were showing the slide that kind of outlined what an ideal single-payer system would cover, it didn't mention mental health. Because so much, and that is sort of the...
I would like to go back, because it definitely covers mental health and substance abuse.
The House bill covers it as well.
Okay. Well, then maybe I don't have a question, but maybe you could talk a bit about what other countries have done to sort of head off, since there's such a behavioral component to so many sicknesses.
Wow, that's a tough one. I don't want to promise that that instituting a single payer plan is going to solve the mental health problems of the American people overnight. But I think if we are covering mental health equitably, then someone who has their first psychotic break at 19 can get treated and stabilized instead of being perhaps uninsured and unstable until they become until they fall down the socioeconomic ladder low enough to qualify for Medicaid. So I think if we can treat things more quickly, we could, I believe, significantly impact what ends up becoming dual diagnosis, which is people become mentally ill, they can't get medicine, they end up using substances as self-medication, and now we've got a problem, we've got a person with two problems. Now that's talking about serious mental illness, but I'd like to also talk about stress and anxiety. There's an oncologist who her entire focus of research is on the anxiety and stress that cancer patients and their families face dealing with how they're going to afford their cancer care. And I think that's a shame. I don't think people should have to get a diagnosis of cancer and then a superimposed anxiety disorder worrying about how they're going to pay for it.
Thank you.
You're welcome.
Hello, my name is Mary Alice McKean. I've read some articles that say that politically, if the insurance companies oppose single payer, it's not going to happen. And that's based on the fact that, you know, they were for the Affordable Care Act, they were for adding the drug benefit to Medicaid, and they were pretty instrumental in stopping the repeal of the Affordable Care Act. And so this is probably, you know, people that are in favor of single payer, but it does seem that if the insurance companies have been a somewhat progressive force in expanding access, and that if they are dead set against this, which they will be, that it's just not politically feasible. So I'd like to know your opinion on that.
Does anybody want to?
Sure, I'll jump in on that. So universal health coverage is not a new concept. I mean, I think it goes back to even Franklin Roosevelt tried to get universal health coverage in the United States. Truman then followed up with it. Nixon tried to do it. One of the Bushes tried to do it. Clinton obviously tried to do it. Reagan tried to do it. I mean, it's not, I mean, again, I don't think that it's just the insurance companies that would oppose it. In the past, it's been labor unions, the medical association, the hospital association. I mean, there's been a lot of different large associations that have opposed going to some kind of a universal coverage because of what they felt was going to be the backlash. You know, it's like it was going to lower provider rates, or it was going to influence labor unions' ability to attract skilled workers. So whether the insurance companies would oppose this or not because of, you know, they supported the Affordable Care Act.
And I would add to that I wouldn't exactly describe the behavior of the insurance industry as progressive around the Affordable Care Act, although I won't use any four-letter words.
Well, they did support it.
They supported it
because it preserved their
them.
Role.
Right.
Yeah,
They actually
no,
spent $5 million a day between the American Health Insurance Plan, AHIP, that association, the pharmaceutical industry and the medical device industry and the hospital industry. Between them, they were spending $5 million per working day throughout 2009 to lobbying the members of Congress to make sure that nothing got into that piece of legislation that would negatively impact their ability to make a profit.
And that's a fraction of their profit margin.
I think it covers the daily payout to their CEOs, actually.
So I'm not here to vilify the insurance industry. I'm simply saying that as a businesswoman, because I was a businesswoman trying to run a solo practice, and I saw my costs going up and my income stagnating, and I wanted to provide health insurance for my employees, and year after year those costs kept going up. And there is actually a group called Business Leaders Transforming Healthcare that it has just started. It's already got 170 members, and these are businesses that are supporting a national health program because they know that if they could divest themselves of the responsibility for providing health insurance for their employees, they would willingly pay an employer tax.
Which is 6.2% in the new bill.
Right, which ends up being less than what it would cost them to negotiate insurance over and over and over again.
It's about 50%.
And they would grow jobs because with that money that they're not spending on health care, they can actually give their employees a raise, or they can build their business
That's
and
all
more
the time
jobs.
we have. We've been chatting with Dr. Carol Paris, Sandra Heffern, and Dr. David Miller. I'm Andrew Kitchenman. Thanks for joining us on Forum at 360.
Funding for Forum at 360 comes from Rainbow Foods of Juneau.